Hello everyone. We're glad that you were able to join this session and get to know a little bit more about this project. We're going to share today about the culturally and linguistically appropriate vaccine education that has been a collaboration between the Institute for Global Health Science, Stanford Digital Medic, and Maya Health Alliance in Guatemala. So we can move to the next slide. And we come with one representative of each of the institutions. So from my side, my name is Rubi, and I'm the representative of Maya Health Alliance and the contact to get in touch with the community health workers and the people we work in Guatemala. Please, Lucía, introduce yourself a little bit.
Yeah, thank you. And thank you everybody for joining us today. I'm Lucía Abascal and I'm a postdoc and global health researcher at the UCSF Institute for Global Health Sciences. And I'm very happy to be part of this conversation today. And yeah.
Hi, everyone. I'm Semay Johnston. I'm the Learning Experience Designer or Director of Digital Medic, which is a program within the Stanford Center for Health Education. So our team brings together experts in medicine, learning design, and global health research to create and evaluate high-need health education.
Thanks, Semay. Thanks, Lucía. So what can you expect from this time that you're going to hear from us? You're going to hear about the vaccine context in Guatemala, and the project phases, that it was phase 1, formative qualitative study, phase 2, development of educational videos and job aids in Spanish, Quiche and Cachiquel, that are the Mayan languages spoken in Guatemala, and the phase 3, the launch of the educational videos in Spanish, Quiche and Cachiquel, the results, and the next steps. So talking a little bit about the vaccine context in Guatemala, Guatemala, it's culturally diverse population, millions who identify as Indigenous Maya, and this is the richness of our country. And despite the historically strong childhood immunization coverage, rates have declined in some areas, potentially due to the COVID-19 pandemic's impact on vaccine confidence. And also cervical cancer is the second most common cancer among women in Guatemala, and the leading cause of cancer-related deaths among women aged from 15 to 44 years. HPV vaccine reduces the risk of cervical cancer, and only 34% of eligible girls have received the first dose, and a mere of 15% have completed the vaccination series. So given these populations are at high risk for severe disease outcomes, we aim to better understand why these groups were not accessing to HPV and routine vaccines and develop an intervention to address these barriers. We can continue with the project phases. Lucía?
Yeah, perfect. Thank you, Ruby, for that background. So our project was divided in 3 phases, which we'll mention and walk through in the project, but just as an overview, phase 1, we did a formative qualitative study to really understand what the barriers and enablers for vaccine uptake were in these communities, including myths, misconceptions, but also access barriers and beliefs. Then based on that, we used this knowledge to develop the educational videos and job aids in the languages of our target communities, which were Spanish, Quiche and Cachiquel. And then lastly, the interventions was launched. So we launched 2 interventions. Well, one kind of same content, but in 2 different ways. One through social media focused in the community, and then one through WhatsApp targeting healthcare workers. And here in the bottom, we have like a diagram that's the human-centered design process we used in the development of our project. We will be referencing this diagram throughout the different phases. So it has 5 phases, including the analysis, design, development, implementation, and evaluation. And you'll see that throughout there are various loops. And this signifies kind of like the feedback loops that exist within each process. It's not a straight line. We receive feedback, we iterate, we receive feedback, we iterate. And that way we were able to really tailor our interventions to the communities we were working with. Next slide. So I will start talking a little bit about phase 1, which was a formative work. Next slide. So in this phase, we are focusing on the first part of the human-centered design process, or the analysis. And here we had 3 different methods we used. So initially we had 2 ideation sessions with healthcare workers. These were just discussions to really understand the communities we're working with, the general feel of the project. And this included 13 community health workers, 2 nutritionists, and 1 physician. And these were more like closed conversations with the group. Then, following that informed the development of the interviews, of the interview guide, which guided both in-depth interviews with community health workers and 9 focus groups discussions. Next slide. So our interviews were focused on gathering insights on barriers to childhood immunizations, including HPV vaccines, to identify common misinformation and myths about vaccines, and also assess what both community workers and healthcare workers assess as trustworthy, what is viewed as trustworthy. We also asked about social media, how they gathered information, where they gathered information, how they shared health information. So really try to understand how inform our intervention. We ended up doing 9 focus groups with 41 community members. Focus groups were all done by community members and were done in the language of the community member, the language that the community members spoke. And then we held 16 in-depth interviews with community health workers, nurses, and physicians working in different areas of our target communities. And this included healthcare workers from NGOs and also from public clinics. Next slide. So we have a lot of findings. They were very, very rich interviews, but here's like a synthesis of our main findings. So there were many common myths and beliefs that match previous literature as well, mainly that the HPV may cause infertility. There's also a myth that a concern that HPV vaccines might allow unrestricted sexual activity in young girls. In general, so this is about just in general immunizations, some believe vaccines can cause severe illness. And then sometimes vaccines are viewed as unnecessary. And this is something we saw with the generational change. So there were a couple of people that referred to their grandmothers or mothers-in-law or any other older caregiver that said that we never were vaccinated and we are okay. So why would you need to be vaccinated? So that was a lot, something that came up a lot in the interviews. There were also significant access barriers. So this could be delays due to supply issues. So mothers would go to the clinic, but then they wouldn't have the vaccine and sometimes they didn't come back. There were also a lot of people that talk about how they health workers worked to solve this, for example, doing house visits. There were some lack of information about dosing schedules and specific vaccination dates. So many caregivers didn't know what vaccine was next or when it was next. So it was up to like the healthcare system to provide that information. There were some confusion about eligibility for certain vaccines and concerns about side effects. In terms of trusted vaccine information for Indigenous communities, there was a need for messages that support vaccine safety and focused on how community members that are viewed as trustworthy have been vaccinated, content that emphasized that vaccines protect against serious disease, and there was a very big need for messages in Indigenous languages because there were many people cited that there was not enough information in these languages. And I mean, these are like kind of the negatives we found. It's important to note that we did find a lot of positive and really great work being done by community-based organizations and clinics in the region, including, as I mentioned before, door-to-door visits, nurses following up, a lot of very invested healthcare workers that really, really wanted to get every child vaccinated. But this is what we used to inform our video. Next slide. So these are just two of the quotes we selected. There's a lot, and we are in the process of polishing this initial paper. So one community member from a focus group said that many mothers are not going to give them the HPV vaccine, their girls their HPV vaccine, because they're scared that they won't be able to be mothers, and that the younger they get the vaccine, the like more infertile they get. And this is a common misconception, not only in Guatemala, but also like in other countries in Latin America. And then a healthcare worker mentions, and this is going back to like the lack of information. So we also heard a lot from healthcare workers and community members that even though they mostly accepted the vaccines, they didn't know a lot about the vaccines. So they were kind of like just given the vaccines without the information. And there was this need to have the information. So this healthcare worker said in the interview, if I don't know how a vaccine works, I am likely to accept or choose it. Also, misinformation and limited access to accurate information contribute to these doubts. And they also mentioned how these were increasing as people questioned more and more vaccine safety. And next slide. So I will give the room to Semay to talk about our intervention development.
Thanks, Lucía. So in the second phase of the project, we took the rich information gathered from the formative study and used it to develop the educational content in Spanish, Quiche, and Cachiquel. So in each of the languages, we created 3 videos about HPV vaccine, 3 videos about routine immunization, as well as summary infographic job aids for each topic. So next slide. You'll remember from Lucia's introduction that we use the human-centered design process combined with the ADDIE model of instructional design. So we're gathering feedback and iterating on our design throughout the entire process from ideation to final product. And the feedback comes from a community relevance team of 10 local Wuqu Kawoq staff, health workers, and community members. We also had guidance and feedback from medical experts at Stanford University and the Center for Disease Control in Guatemala, and final review and sign off from the Ministry of Health in Guatemala. So this visual, it simplifies the number of feedback loops, which were really happening on an ongoing basis throughout the key stages of production. So on the next slide, you'll see those key stages, kind of going from start to finish. We start by defining the key messages based on the formative research, then develop the creative approach and visual style for all of the content. Then we write the scripts translate in each of the languages, create storyboards, art assets, record local voiceovers in Spanish, Quiche, and Cachiquel, and animate all of the videos in each of the languages, and then finally creating the job aids, summarizing the key messages. So I'll go through in each of those in a little more detail next. So for the key messages, we really start by, taking the learning from those early focus groups and interviews to distill down what is the most important information that needs to be communicated in the content. So for all of the content, we defined as overarching messages, vaccines, firstly, that vaccines are part of your right to health and wellness. So framing it in a very positive way. And also valuing the parent-informed decision and affirming the parent's intention to protect their child. We also emphasize throughout all of the content that vaccines are safe and effective for protecting against severe disease. Then when we drill down into the specific topics, the HPV content, these are the key messages for each of the videos. First, really emphasizing the connection between cervical cancer and HPV, that it's caused by HPV, which is preventable. Then we debunk myths about the vaccine causing infertility, and then explain the timing of the vaccine and who gets it, really kind of addressing that misconception that, why do young girls need to have this vaccine, and that it protects against something that can develop much later in life. For routine immunization, we really dive into the importance of completing the full recommended schedule, and that being the best way to protect against serious illness, and that, you know, even if there are barriers or you miss a dose, it's never too late to catch up. Secondly, really helping to understand common side effects, that they're normal, and how you can manage them. And also just addressing some misinformation and sources of hesitancy, confusion about why there are so many vaccines and if they're all needed. So after defining the key messages, we can go to the next slide. So we think about the creative approach that we're going to take in the videos to effectively communicate those messages. We took two approaches. One of the videos on HPV, we told a first-person story about 3 generations of women in a family affected by cervical cancer. So we chose this format to just enhance the emotional impact of the message and affirm the mother's decision to protect her daughter against the life-threatening disease that comes much later in life. For the other videos, the information is given through conversations between families and a community health worker who's seen as a trusted source of information. And it also serves to model how conversations like that might look as an opportunity to ask questions and learn from the CHW. So these images are still these are still frames from the final videos. At this stage, it's still conceptual. So next, we define a visual style for the content. So this was informed by input from the community relevance team so that it reflected the communities we were creating the content for. Local influences were used in the character design and the settings in the videos, which you can see in detail, such as hairstyles, clothing, and what the homes look like. I also want to take a moment to acknowledge the talent and hard work of the Creative Frontiers artists and animators who produce the visual content. So next, we develop scripts for each of the videos to effectively communicate the messages and the learning objectives that we had defined earlier. These were translated and further refined with input from the community relevance team, especially the team at the staff at Wuqu. They provided insight into specific wording, such as how people in the community refer to cervical cancer as cancer of the womb. So making sure that we're using language that makes sense and is understood with the target audience. So storyboards are also a way to further refine. They show the script alongside simplified visuals. And these help to refine the script, the pacing, and visuals when it's still relatively quick to make adjustments. So as we developed all of these for each of the videos, we were getting feedback and making adjustments before moving on to the more finished assets. So on the next slide, you can see some of the art assets. This would be the next level of production. These are the visuals that get used in final animation. So you can see on the right side some comparisons of before and after of some of the adjustments that were made based on feedback. So on the top, you can see changing the home setting to more closely reflect the homes and the communities that we were creating for. Then adjusting the style of the ball to more common Guatemalan ball. Other details like what vegetables might be available or how the baby is carried on the back instead of the front. Next slide. So voiceover and animation. Each of the videos was produced, well, first in English, but then also in Spanish, Quiche, and Cachical. And the Wuqu team worked with local members of the community to record the voiceovers in the local languages and accents. So as we're presenting in English today, we're going to play parts of 2 videos in English just so you can see the final outcome of the work we did, and then very short clips of how these looked and sounded in the other languages. So we can go ahead and play this video.
My mother was a vibrant soul.
Are you able to hear
But
this
we
audio?
lost her too soon to cervical cancer. I later learned that it's the second most common type of cancer for women in Guatemala, even though it's preventable. I didn't want my daughter to face the same risks, so I did my research. I learned that over 90% of cervical cancers are caused by the human papilloma virus. But there's hope. The HPV vaccine can prevent cervical cancer. And early detection through regular cancer screening saves lives. I choose to vaccinate my daughter to protect her from getting cancer. It's not just a vaccine. It's her right to health and wellness. My mother was Rosa, I've heard so much about vaccines lately.
Sorry.
And I'm feeling a little bit overwhelmed. There are so many vaccines, and I'm unsure why they are all necessary. Irma, I understand your concerns. Working in healthcare, I've witnessed how vaccines protect our children against disease like pneumonia or diarrhea. But why does my baby need so many shots? And all at once? It's a good question. There are many bad diseases that our children can suffer from, which is why there are several vaccines. So it's great news that vaccines have been developed to protect children from more of these illnesses. Also, scientists have spent many years making sure the vaccine schedule is safe. I have missed a few vaccine appointments. Is it too late? No, Irma, it's never too late. It's crucial to get any missed vaccines as soon as you can. There is even an age-appropriate catch-up schedule that ensures children are safely protected, no matter when they get their shots. Thank you, Rosa. I feel more at ease now. I'll make sure my baby gets all the shots he needs.
They are all available on YouTube. So just wanted to make the point that we did create all of these with the local voiceovers, and this animation is done at the same level of quality. Last but not least, we created the visual summaries. These are the job aids that are covering all of the key messages on both HPV and routine immunization in each of the languages. So these were sent to the community health workers in the next phase of the project.
Okay, so then after all that hard work, we can move to the phase 3, that is the launching of the educational material in their Mayan languages. So on this stage, before launching the educational videos, we were in the loop of the implementation and evaluation from the Ministry of Health, which we needed like their feedback in order to the material be approved. So this was something that takes a little bit of time because they really care about every details, and they wanted to make sure that we were sharing the scientific and the accurate information with the people in Guatemala and the community health workers as well. Next slide, please. Then we launched the material with 2 arm intervention groups. One was the community focused on social media intervention, and the other one was the healthcare worker focused on the WhatsApp intervention. And we're gonna discuss a little bit more of each of them on the next slide, please. So the first arm, that was the community focus on social media intervention. This was content covered by Facebook or Instagram in all the 3 languages. across various departments in Guatemala for around 3 weeks. So on this slide, you're able to appreciate the Guatemalan map and the areas where the video was launched. So it was some areas of Solola, Quiché, Chimaltenango, and Zacatepeques in the community language. And we were monitoring also the people reaction to the videos, the comments, and we were just checking if it was well received or not. And we were able also to appreciate the beliefs and myths that Lucia shared about in the beginning of the presentation. Can we move to the next one? So we have an example of how ads were across Facebook and Instagram launched on the specific community that we needed it to be launched. So here we can check on Facebook and the reactions we were having. And this was a great teamwork because we were able to monitor how numbers were across Facebook and Instagram. That's according to the community. So please, Lucia, if you can continue with the media metrics.
Yeah, so we used that to, well, for the Facebook and Instagram intervention, we used like two ways of measuring it. So the first one was through the social media metrics, which are metrics that both Facebook and Instagram gives us of the performance of our ads, which were the ones that we just saw. And here are the performance measures for the 6 videos by focus, routine immunization, and HPV. The campaign was very successful, so it reached in our target community. So these were in like the 12 communities we included in our study. It reached 4.1 million people, and the ads were seen 6.6 million times. So our intervention was very successful in terms of numbers enriched. Yeah. Next slide. Additionally, something that's very important and an important aspect of our project, and I think a very important consideration if you're thinking of employing social media as a health intervention, is that we also wanted to hear from people that were on the ground in the communities we were trying to reach. So not only are we using the social media metrics to evaluate the reach and impressions, but we also used community health workers to go to the target communities and interview people through a survey to understand first their perceptions around vaccine, HPV, so additional information to just like their beliefs, but also to tell us about their exposure to the videos. And then people were shown some of the materials and videos, and we gathered insight directly for them. So despite social media platforms obviously allow you for this wide reach and dissemination, but there's also a piece of like the face-to-face interactions. And this is what we saw. So here are some pictures of our surveyors going to the communities and interviewing healthcare, community members. And one of our we were interviewing people that were decision makers for children regarding vaccination. So those were the people we're trying to interview. We ended up recruiting around 620 caregivers, which is a great number, among the 12 communities our intervention was focusing on. Next slide. So here are additional pictures, and you can see that participants, like the one on the right has her little kid, and these were all done in Qualtrics. Everybody signed their informed consent. They were obviously, we provided incentives, but they were free to participate or not on the survey. Next slide. So what we found through our survey is that there's a high vaccine acceptance in our communities for childhood immunization, but there are some worries about side effects in vaccine ingredients. In terms of HPV, it's not that positive. There's a big lack of information and knowledge. So 71 participants had heard about HPV, but only 44 knew it caused cancer. So there was a very big disconnect there. And almost everybody agreed, or everybody agreed that cervical cancer is serious, but only 43% of people knew that it was prevented through vaccines. So another big disconnect there. And 95% 95% said that they would vaccinate their daughters if there was a vaccine to protect them against cervical cancer, but only 34 had vaccinated. Of those that had girls under above 8, which is the eligibility age in Guatemala for the vaccine, only 34% had vaccinated against HPV. And this statistic matches the Guatemala national statistic on HPV uptake. And then in terms of our content, so this is, I think there's this misperception that these communities, not only in Guatemala, but worldwide in different communities I've worked with, there's this misperception that people don't have access to social media. What we found is that in our communities, and this matches previous research we've done with other vaccines, that most people do use social media and that they use it a lot. And then 21% of the people we interviewed reported seeing the intervention video primarily on Facebook. And then most of the people reported learning something from the video, felt more comfortable vaccinating children after the videos, and 86% said they would make an appointment for vaccination following the video. Next slide. And Ruby will talk a little bit more about the other intervention, which was via WhatsApp.
Thanks, Lucia. So that was according to the community launch material. Now it's the arm of the healthcare workers that was focused on WhatsApp. So we recruited 238 health workers in the 12 communities to participate in the study, in which 156 were consented. And the participants were recruited from also NGOs and clinics working in our target populations. We got also the secure approval from the Ministry of Health, which also was needed in order to contact them and be able to share the material with them. We also sent the vaccine-related content in the courses, in the course for around a month, including all the HPV routine immunization videos that we saw previously, and also the infographics in the 3 languages. We shared text and reminders related to the content and all these were scheduled and sent. So we worked with draft and we set it up the dates we were gonna send the messages, send the materials in order that we can finish the course in a lapse of 1 month and a half. There was a two-way communication with the community health workers. We had team members responding and helping them in order to complete the surveys, for example, or also if they may have any question, like if they were able to share the material with the patients or with their family or with their friends. So we were sharing the responses, and we're gonna share a little bit of that interaction in common slides. And we also give a follow-up with pre and post surveys collected through WhatsApp in order to listen to their experience before sharing the material and at the end, and get to know what was the learning or their perspective from the material shared. We can move to the next slide, please. So here you can see how the community health workers reacted on WhatsApp. So we usually share on the first screenshot, you can see the job aids shared, and we specified the language it was also written, and they were really thankful about receiving the material. On the second slide, you can appreciate that we needed to give some guidance on completing the survey because they were asking that they were able to get through the link. And on the third one, we can see that they were also actively participating because they were even sharing a screenshot when they completed the surveys. Next slide, please. We also got like really good feedback from them. Like they were really thankful that the material will share in the communities, and that's because we were sharing this material, and we agree with them that they can share it with anyone that was needed. Next one, please. There's also a reaction from people that they share that it was really important that the material was shared in their native language, and that it was also focused on the scientific information, and they can break those barriers of the beliefs that the community had faced. So this is one of the response of the community health workers, and it was really, really well received by them, by everyone in the communities. They can also see how we shared the link from the YouTube list of videos that we have. Next slide, please. So here's another screenshot of the content shared through WhatsApp and how they were able to see it. We have the links on YouTube according to their language that they needed to watch it. And here's the list of how they were able to watch it. So this really helps them to have the material in any place, even though they don't have internet, because they have on the compressed video on WhatsApp, and they also have it on YouTube. Next slide, please.
So this intervention was also evaluated through a pre and post study design. So healthcare workers received a brief survey through WhatsApp before the intervention and then after. What we found is that vaccine acceptance is high among health workers, where 80% strongly agree that it's safe, efficient, and important. Then in terms of the intervention, they found 90% found the infographic job was helpful for them, but also for their patients. And most of them used them in their patient conversations, which is something we had found on the qualitative interviews, was that they did not have like enough information aids to share with patients. We did not we did not observe any difference in vaccine confidence between arms, because our sample was already very vaccine confident, except in health workers. The health workers that received the intervention via WhatsApp were significantly more likely to strongly agree on the vaccine safety of HPV. So the rest of the measures we compared in the pre and post survey were not. There were no difference except this statement. And next slide. So in terms of next steps, as Rubi mentioned, next slide, we can go to the slide. So as Rubi mentioned, we worked very closely with the Ministry of Health. There was a lot of interest in our intervention. And because of that, I mean, we had to edit and revise many of the videos, but the Ministry of Health decided to use the intervention nationally. So the videos are currently being rolled out through social media, and I think other channels, including like clinics, through the Ministry of Health, which is obviously incredible. And we will be able to reach a lot of more people. We're in the hopes we can also find a way to evaluate that. So next steps in terms of evaluation research is really to measure the impact on national vaccination trends. This takes longer to see the data, so we would need to measure through different points of time and really try to make an association between the intervention and the vaccination trends. So that's coming up. And next slide. So just some highlights and lessons, and I think this is the second project we do related to this in these communities. We did some with COVID first, and the findings are very similar. So there's a lot of culturally relevant materials in local languages, and this creates a void of information, which can increase vaccine mistrust. We also found that research-informed social media interventions can increase the effectiveness of health promotion efforts. Just being able to measure and really show an association between the intervention and intent and uptake is very important. Also, community voices must be front and central. So as you can see, this was a a big collaboration or partnership between us at UCSF, Stanford, and the Digital Medic, and a very strong community-based organization in Guatemala, which in turn works with community members. And yeah, well, collaboration is important. And I think that's it. I think we have some time. I don't know if Semay or Rubi want to add something before we open up for questions. Okay, so I think we can take some questions. We could either like turn off your mic, ask us questions, use a chat, whatever you feel comfortable doing. So doesn't seem like we have a lot of questions. But I mean, I can ask something, and I can ask Rubi. Rubi, what was you are obviously based in well, not obviously you are based in Guatemala, and you are there with the communities and seeing all of that. How do you think that experience on the ground was?
Well, I believe it was something challenging. Talking about getting all the approval from the Ministry of Health, I believe that's a stage that probably timing is not part of the planning that the Ministry of Health had at that moment, regardless to this project, even though they really like it, they appreciate it, and they're interested in get to know more about it, or maybe interested into future projects about vaccination and promoting health in Guatemala. It was challenging because of that point, and also it was impressive getting the reaction from the people that we really cared about sharing information, like certified information in their native language, because they were really they really appreciate that detail, that they were able to understand the whole video without any word like misunderstand, and that also the team in the United States was able to complete this objective with these languages. It was impressive for me. Yeah. Thanks.
Yeah, I think another challenge that we did not mention, but that's also important, was like as we were saying, we're three institutions, so just aligning, for example, IRBs and all those permissions together was also a challenge and can take time. So it's something that we have to think, but obviously we want to make sure that all of those are correctly done and we comply with it. Yeah. So I mean, if there aren't any other questions, we're happy to give you some time back. Semay, anything else you want to add?
Hello.
Yeah.
Is there a contact where we can reach out to ask more questions about, for example, I think cervical cancer is also a big issue in certain sub-Saharan African countries, about maybe replicating what you guys have done here for those communities. There's someone to reach out to maybe talk more and learn more about that.
Yeah, maybe Kat, maybe in the email you send everybody with the recordings, you can send them our contacts and we would be happy to chat more about it. And yes, cervical cancer is a very, very big problem in many countries and something that's easily prevented. Well, easily. We're just saying like getting people vaccinated. So, and Kat just added a contact on the chat. And yeah, thank you for your interest.
Thank you. Great presentation.
Thank you. Cool. Well, thank you all for joining. And if there aren't any other, here, another question in the chat. Perfect. So how involved were the male folk at community level in all your activities? Well, that's a very good question. And I think, Rubi, do you want to start talking about that? Cool.
Yeah, I can share basic, and it was a little bit hard to involve male in this participation in the communities, especially because all the beliefs that we have in Guatemala and that culturally participation for men in different parts of Guatemala. And usually males are the ones that work and not care about children. So that's the roles that we have in our country. But we did find some male participation on the community arms. Yeah. Lucia, if you want to complete this, it's something else.
Yeah, and I think we can mention more about that. In Guatemala, women take a bigger role caring for children and being their decision makers. In the qualitative interviews, we did find some people mention the role of their partners or even their in-laws, their mother-in-laws, in the health decision making for their children. So that was a component in the qualitative. Some participants mentioned that, in this case, fathers were beginning to take like a more participatory approach to health decision making of their children. We did hear a couple of times that many times fathers did not want their kids to be vaccinated. It was not very prevalent, but we did hear that. And in terms of the survey participation, we did recruit more, significantly more women than men. And as Ruby mentioned, this was, there's some also bias in terms of how the surveys were done, because they were done in the middle of the day in the markets where it's more prevalent to see women. Also, more women identified themselves as the carers of their and decision makers for their children. And then some interviewers in our exiting, like when we briefed with the interviewers, some said that some men got uncomfortable when being asked about specifically like HPV questions. So different barriers. We do think obviously there's a bigger role for men to be involved, and they were included in the study. They were not excluded. It was just how things kind of played off. But in terms of exposure to the intervention, we didn't like target by gender or anything. It was just everybody who participated. Yeah. Yeah, you're welcome. More questions?
I think no. Thanks everyone for joining.